All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So before I talk about the Remdesivir, I wanted to make sure when I was closing down, I saw a comment by one of the cool beans that the report that I showed was from, it happened sometimes from this computer. So this analysis was based on this report. That is correct. And in this report, if you see here, and the data that I was showing was the data that I could get. I'm so sorry, this computer does it. So for example, here, if you see Delta cases, greater than 50 years of age, greater than 21 days post 2 days, or received 2 doses, 21,000 cases, unvaccinated 3,440 cases, greater than 50 years, lesser than 50 years, 147,000 cases. And then there are deaths within 8 days of positive specimen data. And if you see here, received 2 doses, 389 versus 205. There is another video I did that says 50 plus death rate in UK, in which I had looked at the similar data from a previous report. I thought that cool beans who had been with me, they know that I had done this comparison before. In here, what is missing is the population and then the percentages. These are absolute numbers. These are not percentages. So what you do is you take this absolute number, then you look at the population and do the math. It's just that for me, this data, although it is not this data on which this report is based, because this data is up to 2 July, but till the 2 July, they have done all the math here. That is why I showed it. And I would doubt that till the 2nd July, the math looks like this. And then within August timeframe, the math just became totally incorrect. It is just the same math has to be done to this as well. So please, if you like, you can do it. It's not that I'm trying to switch the data to not show it. Somebody had made a comment that doctor is not allowed to show the deaths. This is data. You can look at this data and I can look at this data. So there is nothing hiding here. My reason, I should have explained in my last talk, I used this data point because this was all done. Not only they have taken the deaths, they've taken the population, they've done the calculation of per 100,000, they've done the lower limit and confidence interval of one to the other. All that needs to be done here. These are absolute numbers. So because of that, I did not do this, this math here. But if you wanted to see how the math works here, then I have done a video. It says UK 50 plus deaths, in which I took data from here and then extrapolated and did the math on it. In there, my limit with the data was I didn't have the exact statistically provable population sizes, and that became an issue. So this is why I stayed out of this data. But I wanted to make sure that we can look at the trend. If you look at the trend here, and if you still feel that after looking at this trend, it is possible that from 2 July, so that is the month of July and August, and now half month of September, in this 2.5 months, the situation has totally changed, then it is totally possible, and we can look at that. I don't think it is that way, because the data here is also not going to show that. I can do a very quick rough math with you. 389 cases of deaths within 28 days of the positive specimen versus 285. Now, 389, the population that is vaccinated is now a very large population compared to the population that is not vaccinated. So if you go back to the population sizes, so if again, now this is 2nd July's data, and I do not have the population breakdown by age. That is exactly the problem I had today as well. But if you look at the population breakdown, you would actually see that the population sizes are very different. And when you then take the rate, you would once again arrive at a similar number. So this number would not show 754% difference, but that's, please do that data math as well. If you want, I can do that math with us tomorrow. I am not sitting here to say that one way is good or the other way, just looking at the data and saying this data does not back the opinions that I'm seeing. Okay, so with this, let's quickly look at the remdesivir side. So here, let me close these numbers. Here is a report. This is a case report, not a study. Case report means that some doctors looked at some cases and are reporting them. Marked sinus bradycardia associated with remdesivir in COVID-19. So that is the report. And in this report, they've talked about patients having bradycardia to the point that dangerously low levels, 40 and below. It is that low level of heart beating or number of beats per minute, that low, can actually cause so much of a drop in blood pressure that heart itself can become impacted and strokes can occur. And so there can be a lot of damage that can occur. So here, they've talked about this. They have talked about how they were managing these patients. And one part of that is remdesivir. And then here is what is interesting part, which I wanted to discuss with you, the mechanism of how remdesivir is causing this problem and how are they looking at it. So let me just very quickly read it here. Despite the rare incidence of cardiac side effects of remdesivir, a possible mechanism exists on review of existing literature. The inherent safety and efficacy of remdesivir, like that many other antiviral nucleotide analogs. So remember, we've done this talk before. Remdesivir is raw material. It mimics the genetic raw material. So when new copies of the virus are being made, and the copy making enzyme, which are called polymerases, when a polymerase takes up this remdesivir as a brick to use in the genetic material manufacturing, remdesivir poses as a brick, but then it is kind of a bad brick. And when it is installed in the genetic material, the whole genetic material crumbles, and the manufacturing unit, the ribosomes, they crumble as well. The polymerases crumble too. The whole thing just falls apart. That is the function of it. So because it looks like nuclear it looks like raw material to make genetic structures, it could look like a raw material to our enzymes as well, and it could end up making incorrect genetic structures in us too. So in our body, the possible effect is on mitochondria. And I would explain that in an illustration. The other possible effect is here that it can act as an, so let me just read it and then we'll see in the illustration. In studies performed during Ebola pandemic, remdesivir was found to have an affinity for viral polymerases. Polymerases are the enzyme. Imagine they're builders, polymerases. They pick up Lego pieces, which are genetic material, and they put them together to make things. So if you are putting the Lego pieces together, you yourself are a polymerase. And then the Lego pieces are genetic material, raw material, with which you are making DNA or RNA. So remdesivir for viruses have their polymerases as well that would make their genetic material. The remdesivir had 500 times or more affinity for viral polymerase. That means if you put human polymerase in front of it and viral polymerase, it would attack and be attracted to the viral polymerase 500 times more. So it would leave our polymerase alone and go and attack the viral polymerase. That is its normal behavior. But there is nothing to say that it would not attack our polymerase as well and kind of disrupt that too, and that would make the side effect. So it has 500 times more affinity for the viral polymerase compared to human mtRNAP. mtRNA-AP is human mitochondrial RNA polymerase. And I'll explain that in the illustration. Although this affinity for viral RNA polymerase over H mitochondrial RNA polymerase is significant, the possibility of human mitochondrial RNA polymerase involvement and subsequent mitochondrial dysfunction is still possible. So one takeaway from here is that our mitochondria can reduce their function. If mitochondrial function is reduced, our heart can become affected because heart is very energy consuming tissue. It is working all the time. We can rest. Heart cannot rest. You cannot ask our heart to go take half an hour's break and then come back and work again. It has to work all the time. Because of that, it needs energy all the time as well. Because of that, its mitochondria are developing all the time as well. So when there is anything that affects the mitochondria, it could affect heart as well. So that is one possible mechanism. The other possible mechanism is that adenosine itself. Adenosine is a nucleoside or raw material for genetic structures. Adenosine can actually act on heart and block the conduction of electricity in heart or reduce the conduction, so that in people who have tachycardia, who have palpitations and heart rate that is increased because of supraventricular rhythm issues, and I'll explain them in a second, adenosine is given to block that. And remdesivir has a similarity to adenosine. So remdesivir, when given, can act as a blocker for cardiac conduction and also cause cardiac toxicity. These are the two primary mechanisms. Let me explain them in this illustration. So here, we have a cell. This cell has a nucleus in the center. Around the nucleus are the energy-producing mitochondria. Mitochondria are actually, you can think of them as bacteria that live in us, that make energy for us, and we give them protection to allow them to live in our cells. So that is a symbiotic behavior. It's a useful behavior for both the parties. Mitochondria are given to us by our mothers. A sperm, when it is developing, sperm would lose its cytoplasm. So what happens is, if I go down here, let's say generally, if this was a cell that would become a sperm, then the nucleus would stay, but the cytoplasm would go away. And cytoplasm has mitochondria. So most of the time when the sperm matures, its nuclear site stays and the cytoplasm just drains away. And because of that, there are no mitochondria in it. It really is just genetic material with a tiny layer on it of the cell membrane. Even that layer starts becoming degraded here. So sperm does not have mitochondria. So that means our fathers do not send the energy-making systems to us. It is our mothers whose egg would contain mitochondria. And when this egg or ova will fertilize with sperm, the mitochondria will be donated to us by our mothers. So back here, this is the mitochondria here. Inside the mitochondria, because the mitochondria itself is a pathogen, I shouldn't call it a pathogen, is a bacteria-like structure which lives within us. It is our energy house within the mitochondria. Mitochondria has its own chromosome in a circular structure, and mitochondria has its own DNA. That DNA has genes on it that make about 13 proteins that are necessary for mitochondrial function. This all happens within the mitochondria. And whenever our cells divide, mitochondria also divide. Sometimes mitochondria divide without cell divisions as well. Our cell can ask the mitochondria to increase in number when the energy demand is more, and reduce in number when energy demand is less. So mitochondria can individually increase or reduce. Inside the mitochondria, there is an enzyme called human mitochondria RNA polymerase. So that is an enzyme. This enzyme lives here and makes RNA from the mitochondrial DNA. And we know that the RNA is used to then make proteins. RNA is a photocopy of a gene. It is a photocopy of a recipe. So let's say you open up a book, cooking book. There is a recipe in there. You make a copy of that recipe. That copy is called RNA. That means when mitochondria are working, their RNA polymerases are working all the time to help us make messenger RNAs. Now, remdesivir has an affinity, if you see here, bottom left, remdesivir has an affinity for the mitochondrial RNA polymerase as well. Although this affinity is much less compared to remdesivir's affinity for viral polymerase. So ideally, if there is a viral polymerase and our polymerase simply means something that makes polymers, that something that builds. If there's a viral polymerase and our polymerase, remdesivir is usually going to attack viral polymerase. It loves viral polymerase more, but it could attack our polymerase as well, our mitochondrial polymerase. If that happens, our mitochondrial function will go away, will become damaged, will become less. When mitochondrial function is less, then what happens is that inside the heart, here, inside the heart, so this is a structure of the heart, I'll explain in a second, heart's function will reduce. That is cardiotoxicity. Now, the second important thing to realize is this. So let's look at this for a second, the structure here. In the structure, at the top here is SA node, sinoatrial node. This little blue ring is a division between atria and ventricle. So on top are atria, then there is a fibrous ring that separates them from the ventricle. Sometimes what happens is, or let me back up for a second, what happens is the electrical activity for our heart starts in the SA node. From there, it goes to the atria. From there, it reaches a point that is between the atria and ventricle. It is called AV node, atrioventricular node. This is just like intersection for the roads. So atrioventricular node is sitting at the boundary of atria and ventricle. From here, all the traffic, electrical traffic, goes to the ventricle. And then when it reaches to the ventricles contract. That is how our heart works. If you can actually see, if there is anything that damages this little tunnel, this little tiny area, then the atrial impulse towards ventricle will be affected. We affect that sometimes when the atrial system becomes imbalanced and there is too much electrical activity started in the atria, and that electrical activity is bombarding the ventricles, and ventricles are running very fast, and we are afraid it would cause lots of issues, including heart attacks or even death. What we do is we try to block the impulse here at the AV node. And one medicine to use for that is adenosine. Now, remdesivir also is an analog for adenosine. So that means remdesivir can also possibly block the AV node and reduce the conduction from atria to ventricle. That means ventricle are on their own many times to do their function, and the impulse that is coming in is really slow, and the heart rate would become slow. So there are two things. One is this mitochondrial damage. Other one is this. Remdesivir can bind with A1 receptors on the cardiac cells and reduce the nerve conduction at the AV node. That would also reduce the heart rate. This can become dangerously reduced below 42, 43. In the cases that I showed you, they were saying that in one case, the heart rate went down to 38. This is really low, because if the heart rate is so low, the blood pressure is low. That means heart will not get its own oxygen in correct quantities, plus brain would not get oxygen. So there can be strokes, there can be cardiac heart attacks, and so on. So it's a dangerous situation. Now, how do they manage? So number one, withdrawing. So this is again from the same study I showed you. Stopping remdesivir use within 24 to 48 hours corrects this situation. The other possibility is, in emergency, doctors can decide to give atropine, and that would help as well. So this is the discussion for remdesivir. Thank you very much for listening to this one. It's an old news, but I thought this was important for us to see, because remdesivir is still very much used, if not here, it's very much used almost everywhere. So thank you very much for listening to this one. I would see you in another few minutes, and we'll do a quick chit chat as well. Please, if you like this work, please like, subscribe, and share. If you would like to support it, there are some links in the description. You can buy me a coffee or be a patron or use PayPal to support it. And I would see you in a few minutes.